It's a very comprehensive discussion that we've had, and there are a number of queries that have come up, and I'm going to summarize these questions. But the one that is put for you, Finn, is you talked about preemptive evacuation. There's one question is, first of all, how are your organization or organizations like you alerted to the person who may be ill or require medical assistance? And how would you suggest and this maybe involve Leo, how do you make a preemptive assessment of somebody who might go off? Is it purely on their risk factors, or their vaccination status, or the facilities and healthcare available in the country? What are the criteria, might you suggest, to get somebody out early before they become too physiologically unstable for medical evacuation?
Okay, so quite a lot of questions.
Yeah, I mean, they all merge together.
But how do we find? I mean, to start at the beginning, how do we find out about cases? Tends to vary depending on whether they're individual travelers who are covered by an insurance company or whether they're with an organization that we work with. With individual travelers, really we have no contact with them until they choose to pick up the phone and contact their insurance company, and then we'll be alerted. So we'll be notified by the insurance company that someone's fallen ill, and we'll pick it up from there. And sometimes that's unsatisfactory because we find out too late. You know, we could have done with finding out a bit earlier. With organizations, we can be a bit more proactive because we can work with those organizations and say, listen, you need to tell your staff that if they've got COVID, doesn't matter how serious or not serious it is, we want to know about it, we're going to want to talk to them. And that way we get a head start, and we build a relationship with that individual so they trust us, because at first they don't know who we are, down the end of the phone. And it also means that if decisions need to be made on evacuation, we've still got time to get the evacuation done before anything goes wrong. So it's easier for us looking after organizations than individuals usually. In terms of the risk assessment, I mean, there is a slide on that, and it's essentially, I suppose you could say that there are 5 pillars of the risk assessment. There's the patient's age and past medical history. So in other words, that defines their susceptibility to severe COVID. Then second pillar is their vaccination status. Third one is how bad they are right now in terms of, clinically. The fourth pillar is what's the quality of medical care available locally. And the fifth one is how easy is it to get this person out if we did choose to evacuate them. So those 5 pillars are the basis of that risk assessment. I don't think we can really get into the precise criteria that we use because it's too technical, but that's how we approach it.
Okay. Another question there is, why do you have to use the pod and not just people in PPE and re-sterilize the jet?
Well, it's an interesting question, actually, and it's something that we've discussed with, there are air ambulance providers that do this with just PPE, but nearly all of them have gone down the pod route, and it's not something that we at Helix can really control. So there are certain areas of the world where we can move people without having to use a pod, but I have to say for most of the globe, the only way we can easily move a patient with COVID or suspected COVID is using one of those pods, because it's the only thing the air ambulance companies will accept.
Thank you. Leo, there's a question which you may be able to help with. There's somebody asking whether the HLA status of an individual predicts the severity of disease that they might develop. Do you know, is there any evidence here?
Well, I think there are indications that some HLA patterns are potentially associated with a more severe cause, but still it does not compare to factors like age. So it's all quite small factors, and so there's no test available, to my knowledge, that you can really accurately predict who is to run a severe course. It's a combination of many factors, and one of those could be your own immune setup.
Okay. There are a couple of questions regarding boosters and how they might be useful to deal with variances. Have you got any perspective on that?
So I think there are two discussions. The first one is, of course, the waning of the antibodies, but as I've discussed before, probably if you have the same strain, you will have a much longer duration of protection against severe disease, although you might become symptomatic again. So from that perspective, depending on what the goal of vaccination is, if it's to relieve the hospitals, then the revaccination or the timing of boosting may be quite prolonged. With the introduction of new variants, it may be quite different, because then, as I've shown, if you have a 10-fold reduction in your neutralizing antibody levels, your protection against symptomatic disease would drop from 70 to 20 or 30. And we still do not know very well how well you protect against severe disease. So in that situation, revaccination with a vaccine which takes into account the variant will be important. Besides that your antibody levels will go up again, which is an additional factor that will help you to protect. And so one of the discussions, I think, at the moment is that whether it's necessary or not, and I think to revaccinate the older people with an mRNA vaccine once they've been vaccinated with a adenovector-based vaccine. And I think that's one of the reasons why in the UK the COMCOV study is currently running, because that will provide an answer and also help us to decide whether this type of revaccination would be sensible. And maybe if the antibodies drop considerably, it might be useful to revaccinate before wintertime next to influenza.
Okay. Finn, an interesting question. The delays that you describe in evacuation and the problems, do they occur in non-COVID patients as well at the moment?
Yes, they do, unfortunately. I think, the COVID patients are subject to more delays than non-COVID, but actually a lot of these delays are not related to whether the patient has COVID or not. So air ambulance evacuation is more difficult across the board for all conditions globally, significantly more difficult than it was before the pandemic.
Okay. Leo, can I ask you a question about the risk mitigation for people traveling, or risk assessment you talked about in your second last slide? Many of the countries that our travelers would like to go to are low middle income countries, and the epidemiological evidence that we would like to base our assessment on is either not available, nor is the data on the variants. How does that come into our risk assessment?
So that's, I think, that's really a black box. So to my idea, especially when you're vulnerable as a traveler, I would not choose to travel to that area at this moment in time. So it's like people that need a yellow fever vaccine and want to travel to, let's say, the rainforest in Brazil, but who cannot, because of their immunosuppression, for example, cannot travel to that area. That's also an area you would not advise to travel to at this particular moment. And I think we are still in a situation where it's completely unclear whether you're protected by the vaccine you've had, and especially also alluding to the healthcare system, which is often stretched already without COVID, and so with little chance of getting healthcare when you are in trouble. So I wouldn't travel, and I would postpone that for another year or two.
So, I mean, by that criteria, there are large parts of the world where it would be unwise to travel because of the lack of information, knowledge, and the limited knowledge we have on the protection provided by vaccines? I mean, is that...
Especially if you're vulnerable, yes, I would think so. Again, yeah, that would be my opinion.
Yeah. Okay, good. Well, that's a very disturbing thought, that we're all looking to travel, but currently the way that the world is, it looks like a long way off.
Yeah.
I'm just looking through the questions here. There are quite a few people asking about boosters. We've already discussed that. There's a question, is travel insurance, how expensive is it? Prohibitively expensive, and is this going to be a problem for our travelers if they do wish to travel now, Finn?
It's not going to be any cheaper. Some travel insurers have quit the business, actually, so there are fewer providers of travel insurance than there used to be. I think it's too early. It may be too early to tell what's going. You know, I'm not an insurance professional, but you know, really, the travel insurance market was broken anyway before the pandemic, because it was just, travel insurance was just seen as a commodity. You buy it off a price comparison website. So who doesn't buy? Who buys the second cheapest? Everybody just buys the cheapest. So there's a kind of race to the bottom, and it's a service that was providing extremely cheap cover, but it wasn't really working well for the customers who were trying to make claims, because they were finding all sorts of problems, and it wasn't making much money for the travel insurance companies either. So so this may provide an opportunity for a reset, whereby perhaps travel insurance is more expensive, but maybe provides a better service than it did before, because there was a bit too much pilot hire and sell it cheap, I think, going on.
Okay. I'm just reading the questions. There's a question here again for you. If the country of origin is poor resource, where do you take such patients? So if I presume that if you're employed by a company and you're a local employee, do you get repatriated out of your country if they don't have the infrastructure, or what's the challenge for you as a repatriation?
I mean, different organizations approach it differently. So we're obviously bound by the rules of the organization that we're working for. A lot of organizations will only have international evacuation as a benefit for expatriate staff. And if people are hired locally in country, then they will be given a local healthcare insurance policy that will allow them to go to local hospitals. But not all organizations do that. And of course, lots of organizations will employ regional staff who aren't actually from that country. So I use the example of a Chadian driver in Burundi working for an NGO. You know, we see a lot of that. And they might be eligible for evacuation. So in a situation like that, we slightly have to go around with a begging bowl and try and persuade suitable countries. In fact, the last time we did it, the country that came through for us was the Netherlands. So thank you very much. It was very generous. And we flew an African patient from Africa to the Netherlands with very severe COVID. I'm sorry to say that he died, but you know, at least he had a sporting chance. But it wasn't easy to secure that admission. And in fact, that was at the height of the Netherlands' last epidemic peak, and they still found room for him. So it was very generous of them.
There's a question here which wasn't covered by Leo, but I'd like, and possibly even Finn, to hear your views on the certification of vaccination status and immunity. That may or may not facilitate travel and risk and so on. Do either of you have particular views on where we should be going, what the benefits or the disadvantages are? I mean, it's a huge subject, but I think the audience will be interested to hear your expert opinions.
So I'm afraid everybody is eager to, you know, and looking at vaccination as the final solution and also a quick fix so that we can go back to our former business. But I'm afraid the certificate of vaccination is just what it is, a proof that you have been vaccinated. It doesn't tell whether the person has protective antibodies. It doesn't tell how well protected he is, especially with circulating variants. And so it has its limits. The chances are that you will be less likely to have symptomatic disease, and so less likely to be admitted to a hospital. But there's still a chance that you will pick up a variant and spread it into your home country. So I'm looking at it. It's really a double-edged sword. On one hand, it's a way to open up borders for those who have been vaccinated, but on the other side, it might well, speed up the spread of new variants that then can escape from the current immunity of the population. That's another reason not to travel too far, in my opinion, again, because it's too early. But everybody is so, eager to travel.
Finn, do you have a view on vaccine certification, and would it make your life easier, or probably not?
I don't really mind one way or the other, to be honest. We'll work with whatever rules are put in place. I mean, I think, I hear Leo's concerns about travel, but I think people are going to travel if they want to travel one way or another. And, if they need to show a vaccine certificate, they will do. If that's not necessary, or if they just need to get tested, then people will jump, I think, through whatever hoops are put in front of them, and they will travel if that's what they desire to do. And what interests me is how I think some of these benefits that are being spoken about, especially the ones in the United States, I'm not sure that they're about preventing infection. I think it's more about sort of bribing people to get the vaccine. If you get vaccinated, hey, you don't have to wear a mask, and you can meet your buddy, and all the rest of it. And I think it's just trying to get people through the doors of the vaccination center, rather than saying that actually these vaccinated people are at so much less risk.
Interesting thoughts.
I agree.
There's a question here. Are countries requesting COVID tests prior to accepting people for medical evacuation? I presume that's probably not too important, because you know they've got COVID and you're bringing them back with a known diagnosis.
Well, unless they haven't got COVID, because they might have a broken leg. So it's a big deal for non-COVID patients. We need to be able to show that they haven't got COVID.
Okay. There's also a question about data and sharing information with local health providers, and having the access to appropriate investigations and images, and is dependent on technology and IT and broadband and so on. Is it a problem for you when you're trying to discuss with providers in low-income countries? Do you have technology problems and discussion problems because of technology restrictions?
Actually, there are technological problems that face us when we're dealing with hospitals in developed countries, just as much as in resource-poor countries, because often there are, hospital imaging systems tend to be on specific formats that are often not compatible with formats that we use in the UK, and so on and so forth. So a lot of the time when it comes to imaging, sometimes we can have access to the original images, but a lot of the time we are going on how those images have been reported and what the clinical interpretation of those imaging reports is by the treating doctors. We don't always have access to the original images. And then, of course, what we will insist upon is that those files that are printed out or put on a CD, or in some portable way, so that when the patients come back, the receiving hospital can access those images. And we always follow up with the receiving hospital to make sure they've got everything that they need? Is there anything that got left behind? Because we can go and get that sent if something got left behind.
Okay, I think there's just two more questions I want to put each of you. The first is to you, Finn. There's talk about oxygenation and at altitude in these travelers. Is that quite a problem for you when your patients have low oxygen saturation and you're at altitude? I suppose you try and fly at lower altitude, but it's always been an issue with air evacuation. And it must be more so with COVID.
To be honest, it's not usually a problem at the altitude. So a typical aircraft cabin will be pressurized to 8,000 feet. So usually you can give additional oxygen to compensate for the low pressure. If you really want to, you can pressurize the cabin to sea level. You don't normally do that for oxygenation reasons, but you might do it if they've, for example, had a head injury and they've got air inside the skull, or if they've got a pneumothorax, something like that. You can, by using special trickery, pressurize an air ambulance cabin at sea level. But unfortunately, it means you have to fly at a lower altitude. So the plane travels more slowly and uses more fuel. So that you don't do it unless it's really necessary, but it can be done. It's not usually necessary for respiratory reasons.
Okay, thank you. Leo, there's a question about nosocomial infection, including mucormycosis and other infections, and this potentially relates to the use of hydrosteroids. What's your views on this, and do you think this is going to be a continuing problem, particularly for people in low and middle income countries, and is likely to cause a lot of problems in the management of severe disease or even less severe disease, but the use of hydrosteroids?
So I think I can imagine that this is a higher risk in tropical countries because of the climatic conditions. But actually, at this moment, we have 4 cases in the Netherlands. First, we had one last week in our hospital, and since there were 3 more cases reported. So actually, we are looking into it. We are using also a lot of tocilizumab in combination with dexamethasone. So I'm not sure whether it's the combination, because as far as I know, in the UK, it hasn't been reported that much. But we are looking into it. But we have now 4 cases since 1 week that have been.
Is that any fungal infection, or particularly mucormycosis?
Mucormycosis. Yeah.
Okay.
Aspergillus we saw in the past, so that was not a surprise. But this was unexpected.
Yeah, good. Anyway, gentlemen, I think that's now most of the questions that have been asked, and I appreciate the discussion. And I'll hand back, I think, to Jane to take over and say thank you to you all.
Thank you very much indeed. That was a fascinating discussion. It's clear that we've still got many challenges ahead. I agree with you, Finn, that travellers are going to travel if they choose to do so. They'll find a way. Leo and I were at an International Society of Travel Medicine conference last week. We were supposed to be in Malaysia, but we ended up in a virtual world as avatars over 4 days. And it was very clear from everybody that we met there that as travel medicine practitioners, we're desperate to get back to travel as well. But I think we've got a little way to go before that happens. But thank you very much, Leo and Finn, and also Ron as well, for all your contributions tonight. It was much appreciated.